Good morning, ladies and gentlemen. My today's lecture is a totally new concept. I will be delivering a series of lectures on clinico-pathological correlation. These lectures will be uploaded in between the regular lectures from the textbook of dermatology Rook. So in these series of lecture, I will be discussing a few clinical terms, and then I will be discussing the histopathological appearances that are associated with that clinical term. These series of lecture will help you understand the dermatopathology more. So let's proceed to today's lecture. You can follow me on Instagram. The learning objectives: to understand how various clinical features correlate with the histopathological appearances, and when it is indicated to take a biopsy, when you are in doubt, and what would you expect in the histopathology report. So just before I go to the individual clinical terms and their histopathology, let's revise the histopathology of normal epidermis and dermis. So from top to bottom, it is stratum corneum, which is also known as the keratotic skin layer. Then there is a rather compact layer, which is stratum lucidum. This layer is significant only in the palmar and plantar skin. Then most of the bulk of epidermis is comprising of stratum spinosum or spinous cell layer. Then the lowermost layer of the epidermis is a columnar layer, which is called as stratum basal, which is in addition to the corneocyte, it harbors the melanocytes. Then comes the dermis. The dermis is also comprising of two layers. The upper layer, which is associated with the retiridges, is a rather compact layer, and it is called as the papillary dermis. And rest of the dermis comprises of rather loose collagen with the associated adnexal structure, and this portion of dermis is called as the reticular dermis. So the first clinical term I'm going to discuss is hyperkeratosis. So by hyperkeratosis, we means thickening of the keratotic skin layer or the stratum corneum. So all those conditions which are associated with thickened stratum corneum are classified as hyperkeratotic condition. And you can see one as seen in this picture. This is a case of lamellar ichthyosis. Now, all the ichthyoses are characterized by hyperkeratosis, that is thickening of stratum corneum, and lamellar ichthyosis is an extreme form of ichthyosis. So as the name signifies, this is a condition which is associated with very thick stratum corneum. So you can see in this histopathological appearance, the stratum corneum is tenfold thicker than the stratum spinosum. So these kind of thick stratum corneum will be seen as these kind of thickened keratotic lesions on the skin. Another example of hyperkeratotic condition, this is bullous ichthyosiform erythroderma, again characterized by hyperkeratosis and some degree of acanthosis. So this is again a very thick and compact stratum corneum. Usually the stratum corneum is basket weave-like. This is the normal stratum corneum you can see here. This is just like the weaving of a basket. And in hyperkeratosis, the stratum corneum is thick and compact. And another feature of all the hyperkeratotic conditions is thickening or prominent stratum granulosum. This is also called as the hypergranulosis. So hypergranulosis is associated with hyperkeratosis, while the another condition which is not going to be discussed at present here is parakeratosis, characterized by presence of nuclei, retaining of nuclei in the stratum corneum. Parakeratosis is associated with hypogranulosis or absent granular layer. So this is the difference between hyperkeratotic and papulosquamous or scaly conditions. So in this histopathological appearance, in addition to hyperkeratosis, hypergranulosis, there is epidermal hyperplasia as well. So these are the examples of hyperkeratosis. That is the focal hyperkeratosis. The examples are callosities, cones, warts, focal keratodermas. Then there are diffuse hyperkeratosis, palmar plantar hyperkeratosis, may be acquired, may be congenital. So it's a huge subject, and you can refer to my lectures on ichthyosis and other hyperkeratotic conditions. So if we take a biopsy from any of these lesions, we'll find the thick stratum corneum, we'll find a very prominent granular layer, and we'll find epidermal hyperplasia. This is hypergranulosis. So there is another condition which is quite different from ichthyosis, but it is characterized by hyperkeratotic lesions. These lesions are in the form of papules and plaques seen in elderly, in relatively fair complexion, type 1 or 2. This is actinic keratosis. So the actinic keratosis is characterized by small papules and plaques with hyperkeratosis and scaling. So if you take a biopsy from any of these lesions, you know this is a precancerous condition. If it is in this form, then it can be treated by topical applications as well as cryotherapy. But if the complication occurs, you may have to remove it surgically. So the actinic keratosis is characterized by alternating hyper and parakeratosis, and then epidermis is usually thinned or atrophic, and epidermis may show partial or full thickness dysplasias. The second term I'm going to discuss today is the lichenification. Lichenification is a term we use frequently in different conditions. By lichenification, we mean three things. We mean hyperpigmentation, we mean thickening of the skin. We mean thickening of the skin and exaggerated skin markings. Increased pigmentation, thickening, as well as exaggerated skin markings. And this is a focal lichenification. Example is prurigo, a very itchy condition, and you can see excoriation or the loss of superficial stratum corneum and stratum spinosum. So the lichenification is characterized by thickening of stratum corneum, but the main feature is epidermal hyperplasia. So lichenification may be associated with hyperkeratosis or may not be associated with hyperkeratosis, but the feature that would be typically present in all the lichenified conditions is thickening of stratum spinosum or epidermal hyperplasia. This epidermal hyperplasia may be regular or irregular, like you can see here in this picture. You can see thin and thick strands or retiridges. This is example of lichen. This example is of lichen planus, which is characterized by lichenification along with these white streaks. These are called as the Wickham strias. And on histopathology, these Wickham strias are actually the hypergranulosis or thickening of stratum granulosum, also known as the wedge-shaped hypergranulosis. So the lichen planus is characterized by hyperkeratosis, wedge-shaped hypergranulosis, and irregular epidermal hyperplasia with basal cell degeneration, pigmentary incontinence, and band-like lymphohistiocytic infiltrate. So third term I'm going to discuss today is the micropapules. There are several skin conditions that are associated with small papules. By micropapules, I mean the papules which are less than half a centimeter or less than 5 millimeter in size, and they are usually skin colored. So you can see these kind of small skin colored papules on the face. There will be many differential diagnoses, but one of the commonest cause here would be lichen nitidus. Here, this is also an example of lichen nitidus, where there are multiple skin-colored micropapules on the surface of the skin. If you take a biopsy, you would find this thinning of stratum cornea, thinning of the stratum spinosum, loss of basal layer, pigmentary incontinence, band-like lymphohistiocytic infiltrate that is restricted to one or two ratty ridges with lipping of or clawing of the ratty ridges on both sides of this infiltrate, and you may find granulomatous inflammation, that is histocytic or epithelioid cell collection within this infiltrate. So this histology is that of lichen nitidus, which would manifest clinically as micropapules or skin-colored small papules. This is also a condition in which you can see many skin-colored papules. Some of them are vesicular as well. So this is a condition which is called as the miliaria profundus. This is seen commonly in hot summer months and mainly on the trunk. On histology, there will be dense lymphohistiocytic infiltrate surrounding the acarine sweat coils. So then there is another condition in which you can see these multiple skin-colored papules, and many of these papules are distributed in annular fashion. And this is a condition that is associated with tuberculosis elsewhere, and it is classified among the tuberculoides, which is the immunologically derived reactions to active tuberculosis elsewhere. So this is called as the lichen sclerophosarum, and lichen sclerophosarum is characterized by small granulomas in the surrounding the hair follicles or perifollicular granulomatous inflammation. So this is one of the example of perifollicular granulomatous inflammation. The other causes is actinitis or actinitis and granulomatous rosacea. So these are the three differential diagnoses of perifollicular granulomatous inflammation. Now, here you also see skin-colored small papules, and if you see very clearly, you can appreciate the vesiculation in a few of them, and if you puncture them, clear fluid comes out. So this is the eruptive syringomas. Histology of these lesions will show many enlarged ducts lined by a double layer of epithelium, and few epithelial strands are seen alone without the ductal formation. Some tadpole appearance as well. You can see this is a tadpole appearance. This is a tadpole appearance. So this is histopathology of syringoma. Here you can also again appreciate small skin-colored papular lesion, mainly on dorsum of hand. So this is the papular eczema. And on histology, there will be spongiosis, but focal spongiosis and limited to a few follicles as well. So focal small areas of spongiosis will be a feature of this papular eczema. Another clinical condition characterized by micropapules, skin-colored papules, flat papules, and you can see this on trunk in young boys and girls. And this is epidermal dysplasia verruciformis, and which is characterized by coilocytes in upper layer of epidermis, that is stratum granulosum. Coilocytes are characterized by abnormal keratinocytes that are infiltrated with viral inclusion. The fourth term to be discussed today is the papulosquamous rash. By papulosquamous rash, we mean a rash which is characterized by scaling. So this scaling can be thick, adherent, silver-like. You can see in this picture, which is typical of psoriasis, while all the other conditions which are characterized by these scaling are classified among the papulosquamous lesions. The papulosquamous lesions are differentiated from hyperkeratotic lesions in that the papulosquamous lesions are characterized by parakeratosis, which is the histology of scale, while hyperkeratotic lesions are characterized by thickening of the stratum corneum. So you will not be able to remove the thick keratin in the hyperkeratotic lesion, but you will be able to remove these scales in the papulosquamous rash or lesions. If we do a histopathology, the most characteristic feature is the presence of thick columns of parakeratosis. And by parakeratosis, we means retention of nuclei in the stratum corneum. So whenever there is parakeratosis, the granular layer is usually absent. So by parakeratosis, we means that the keratinization in epidermis is deficient, rapid, or whatever is the reason, and as a result of which the cells from the basal layer, they are rapidly transforming into entering into the stratum corneum, but in this process, they are unable to lose their nuclei and retaining their nuclei. So as a result, when there is thickened, when there is a thick parakeratotic column, the granular layer will be deficient. In addition, you can also notice the epidermal hyperplasia. So this is a histopathological appearance of psoriasis in which you can see parakeratotic columns as well as the loss of granular layer and then neutrophilic abscesses in upper layers of stratum spinosum known as the Kogoch pustules and uniform epidermal hyperplasia with fused retiridges. This is another example of psoriasis, but now the psoriatic lesions are not in form of plaques, but rather they are small disc-like papules or plaques known as the guttate lesions or guttate psoriasis. So guttate psoriasis is different clinically from the plaque psoriasis, but histologically it will also be different because the lesions are small. There are focal areas of parakeratosis with Monroe abscesses. These are the neutrophils that are present in parakeratosis, and this is a feature of all psoriatic lesions. In addition, you can find spongiform pustules beneath these parakeratotic column, although not present in this picture, with focal epidermal hyperplasias. This is magnification of parakeratosis. You can see these retained nuclei of corneocyte. The nuclei are distributed horizontally, parallel to the skin surface. This picture highlights the Monroe abscesses. So they are parakeratotic columns with retained nuclei, and then there are foci of neutrophils which are present in the parakeratotic columns. Another clinical condition which we infrequently come across is pityriasis rubra pilaris. This is characterized by lesions, plaques with orangish hue, which are scaly, and there are areas of sparing, typical areas of sparing. So if you do look carefully, some of the follicular plugging is also seen, which we'll discuss later. So the histopathological picture of pityriasis rubra pilaris is the alternating columns of hyper and parakeratosis. So this alternating columns are present horizontally in horizontal plane, that is hyperkeratosis, parakeratosis, hyperkeratosis, parakeratosis, as well as vertically, that is parakeratosis, hyperkeratosis, parakeratosis, hyperkeratosis. So wherever there is parakeratosis, there will be loss of granular layer. Wherever there is hyperkeratosis, the granular layer will be intact, and there will be epidermal hyperplasia like psoriasis. But there will be no Monroe abscesses, there will be no spongiform pustules of Kogoch. And as I've already explained, in psoriasis, there is no hyperkeratosis. So in PRP, there are hyperkeratosis as well as parakeratosis. Another example of papulosquamous lesions is a rather acute condition characterized by papulosquamous guttate or discoid type of lesions and in a Christmas tree pattern. And this is clinically pityriasis rosea. And if we do a histopathology, like guttate psoriasis, we'll find a focal column of parakeratosis without Monroe abscess, and underlying epidermis will show some amount of spongiosis. So P. rosea is more like limited eczema. Then another condition which we infrequently come across are the presence of multiple papules. Few of them are scaly, few of them are eroded. And if you remove the scales, the whole of the scale whole of the scale is removed in toto, and this is called as mica-like scale, and the condition is called as pityriasis lichenoides chronicus, or PLC. Histologically, it is again characterized by focal columns of parakeratosis. Rest is hyperkeratosis. And underlying the focal column of parakeratosis, there will be some lichen planus-like lesions or basal cell degeneration and RBC extravasation. You can see here the basal cell degeneration. This is a papulosquamous condition involving the whole trunk. There is a scaly rash along with generalized lymphadenopathy. So there are very few conditions in which the scaly rash is associated with lymphadenopathy, and the prototype of this condition is secondary syphilis. In secondary syphilis, there will be parakeratosis, epidermal hyperplasia, lymphocytic spongiosis, and the most typical feature will be the presence of dense plasma cell infiltrate surrounding the blood vessels with obliteration of vascular lumen known as the endovasculitis. Again, a papulosquamous rash on the trunk. This does not have any particular feature. It's not thick. It's not having a thick scaling or small discoid lesion. It looks like some form of eczema. It could be seborrheic eczema. It could be contact eczema. So if we take a biopsy for eczema, it will be like spongiosis and intraepidermal vesicles with hyperkeratosis and some degree of parakeratosis. Another papulosquamous condition which we encounter in middle and old age, quite itchy, with a lymphadenopathy, but it will not be a generalized lymphadenopathy. So you must take the skin biopsy here because the most common diagnosis is cutaneous T-cell lymphoma or mycosis fungoides, And histopathology will show epidermotropism with infiltration of abnormally shaped lymphocytes within the epidermis. So these lymphocytes may form abscesses known as the Portier abscesses, which are the collection of atypical lymphocytes within the stratum spinosum. You can see this quite infiltrate of lymphocytes in the stratum spinosum. Histologically, the most difficult histopathological appearance to differentiate is the lichen planus. But here, there is an infiltration by lymphocytes, and there is no basal cell degeneration, which may be present, but this is not a feature. So you can, in addition to the histopathological appearance, you can order the immunohistochemistry, and since it's a T-cell lymphoma, you would see the T-cell infiltrating the epidermis by doing CD3 marker. If we do a CD20 marker, which is that of B lymphocytes, it will all be negative. The next term I'm going to discuss is an annular rash. So the annular rash, which is characterized by ring-shaped lesions, is seen in a few clinical conditions. The first one is here. It is an annular rash with quite a bit of itching, and this is commonly known as ringworm. And on histopathology, we do a PA stain, and you can find numerous hyphae, septate hyphae in stratum corneum. These are the septate hyphae seen in stratum corneum on PAS stain. There's another example of annular rash. You can see it on trunk and limbs. And you again do a biopsy here because you have to exclude the tinea. But on biopsy, you will find lymphohistiocytic infiltrate surrounding the blood vessels, superficial and deep. And this infiltrate is in a coat sleeve pattern. That is, the infiltrate is going beyond the vascular, beyond the vessels. So this is erythema annulare centrifugum. Typical annular lesion present in an adult with a dry appearance, loss of sweating, loss of hairs, and you must check sensations of every lesion which is appears to be dry, non-itchy, and annular, because you tend to miss tuberculoid leprosy in a busy clinic. So if you can check the sensations in a busy clinic just by using your ball pen, or do a proper sensory system examination. So what we see in tuberculoid leprosy is the presence of epithelioid cell granuloma surrounding the nerves. And these are also present horizontally, just like erythema annulare centrifugum, but here there is the granulomatous inflammation, and you have to look carefully for the presence of nerve twigs in between these granulomatous infiltrates. The sixth term I'm going to discuss today is the follicular plugging. By follicular plugging, we means the follicular hyperkeratosis. We discussed the hyperkeratotic conditions in which there is thickening of stratum corneum or hyperkeratosis in the plaque. But in follicular hyperkeratosis, this thickening of stratum corneum is seen only restricted to the hair follicles, or the follicles are plugged with this keratin plug, as you can see in this picture, which is that of keratosis pilaris. We frequently see this condition in young male and female, and histologically it is characterized by thick plug of keratin within a hair follicle. Here you can see a wide sclerotic lesion with prominent follicular openings, and all the follicular openings are characterized by a hyperkeratotic plug, And if these keratotic plugs were not present, you would have called this condition as morphia. But presence of these keratotic plug or hyper or follicular keratosis in this condition makes it lichen sclerosis et atrophicans. So there is dense sclerosis here and follicular plugging. So the follicular plugging is the differentiating feature of this condition with morphia. Another condition which is characterized by small follicular hyperkeratosis, along with the scaly plaques and areas of atrophy, and this is DLE or discoid lupus erythematosus. Histologically, on the top, we would find areas of follicular plugging. Then, in addition to these areas, the intervening epidermis will be thinned out and will be showing basal cell degeneration with pigmentary incontinence, and there will be dense perivascular and periadnexal lymphohistiocytic infiltrate. So the infiltrate will be surrounding the vessels, the sweat coils, and the hair follicles. But the basal cell degeneration is restricted throughout the epidermis, and follicles only show hyperkeratosis. And there is an alternating condition which is again characterized by hair loss, but now these lesions are not large and thick like DLE. This is a condition called as the lichen planopilaris. And this is a follicular keratotic condition in which you can see thickened or plugged hair follicles. Along with this, there will be the basal cell degeneration, pigmentary incontinence, and band-like lymphohistiocytic infiltrate that will be surrounding the hair follicles and not the intervening skin. So the last term I'm going to discuss today is the keratotic papules or nodules. So I discussed hyperkeratotic conditions in which there are diffuse hyperkeratosis. I discussed follicular plugging or condition which are associated with follicular keratosis. So these are the group of disorders, skin disorders that are characterized by papule, which is thickened, which is hyperkeratotic. Very common condition, this is the filiform wart, a hyperkeratotic papule characterized by hyperkeratosis, parakeratosis, papillomatosis, which is projection of epidermis upward, hypergranulosis, and the coilocytes, which are the degenerated keratinocytes. They contain the viral inclusion bodies, which you can see here in this picture. Again, a condition which is very similar to wart seen in elderly individuals and is called as the seborrheic wart or seborrheic keratosis, characterized by follicular plugging, then keratotic cysts, and then there will be hyperkeratosis, epidermal hyperplasia, which is characterized by thickening of basaloid-looking cells. On dermoscopy, there would be milia-like cysts. On milia-like cysts, here you can see these milia-like cysts corresponds to the intraepidermal keratin cyst. These are the intraepidermal keratin cyst. And in addition, there will be comedo-like openings. These comedo-like openings represents these follicular plugging, which are present. These are the follicular plugging, which is present in the intervening hair follicles. So milia-like cysts represent the cysts within the stratum spinosum, and then the milia-like cysts are the hyperkeratosis, hyperkeratotic lesions within the epidermal invagination. Uncommon condition characterized by red color papules and plaques. It is called as the clear cell acanthoma, and this is characterized by epidermal hyperplasia with clear cells. And these clear cells are present, can be differentiated or can be separated from the normal epidermis very clearly at the margin of the skin lesion. So epidermal hyperplasia with clear cell is clear cell acanthoma. Another hyperkeratotic papule, this is a molluscum contagiosum. You can see an umbilication in the center of these papules. On histology is very typical, which is characterized by an umbilication and infiltration of keratinocytes with the viral inclusion bodies. These are the intracytoplasmic inclusions, which would push the nucleus of keratinocytes to one side and would be occupying the whole of these keratinocytes. So this brings me to end of the talk. I hope you have enjoyed this clinico-pathological correlation, and you will be seeing further lectures like this in future as well. So thank you and goodbye and have a very good day.